Hello everyone. Okay, let's start today CVS diuretics. Okay, pharmacology diuretics. Okay, to know it, you must be knowing the basics. Okay, so what is the functional unit of kidney? It is nephron. Okay, in nephron there are various parts, and these diuretics they act on different parts of this nephron. So you must be knowing this. There are totally 6 components we must study today. That is, first component is PCT, second is descending loop of Henle, third is ascending loop of Henle, fourth is early DCT, fifth is late DCT and cortical duct together, and the sixth one is medullary collecting duct. So firstly we are going to see different parts, we have seen it, and later we are going to know about the different drugs acting there. Okay, so we'll go with this particular table. It is very simplified manner. So what happens to sodium in PCT? It is reabsorbed. Okay, 65% it is reabsorbed. In loop of Henle descending there is no pump for sodium, so it is not reabsorbed. In ascending loop of Henle there is a pump called as Na plus K plus 2Cl sympod, so it is reabsorbed. In early DCT there is a pump called as Na plus Cl minus pump, so there is sodium reabsorption. In late DCT and cortical collecting duct there is again ENaC channels, so they reabsorb sodium there also. In medullary collecting duct there is no sodium pump, so there is no reabsorption. What happens to water? Water, it is reabsorbed in PCT, it is reabsorbed in descending loop of Henle, it is not reabsorbed in case of ascending loop of Henle, it is not reabsorbed in case of early DCT. In late DCT and cortical collecting duct, medullary collecting duct, again it is reabsorbed. So what are the pumps seen in PCT? Na plus, H plus exchanger and SGLT2. These are the pumps seen in PCT. In case of loop of Henle descending type, there is no pump. For ascending loop of Henle, there is Na plus K plus 2Cl minus sympod. In case of early DCT, there is Na plus Cl minus sympod. Late DCT and cortical collecting duct, there is ENaC channel. In medullary collecting duct, there is no pump. What are the hormones acting? In PCT it is carbonic anhydrase. Okay, carbonic anhydrase. In descending loop of Henle and ascending loop of Henle there are no hormones acting. In early DCT it is PTH. In late DCT and collecting duct, that is cortical type, it is aldosterone acting on RAS. And medullary collecting duct, it is EDH. So what are the drugs acting now? In PCT it is carbonic anhydrase, sodium glucose transporter 2 inhibitors, that is SGLT2 inhibitors, and mannitol. In descending loop of Henle again it is mannitol. In ascending loop of Henle it is loop diuretics. In early DCT it is thiazides. Late DCT and cortical collecting duct it is K plus sparing, that is potassium sparing, and medullary collecting duct it is V2 receptor antagonist. See, I have drawn it here. In PCT it is carbonic anhydrase inhibitors, SGLT2 inhibitors, and mannitol. In descending loop of Henle it is mannitol alone. In ascending loop of Henle it is loop diuretics. In early DCT it is thiazides. Okay. In late DCT and cortical collecting duct together it is potassium sparing diuretics. In the last it is medullary collecting duct, we are going to see V2 receptor antagonist. Okay. We will discuss in detail each classification of these drugs. Okay. Firstly, it is carbonic anhydrase inhibitors, where they act on PCT. What is the mechanism of action? It is non-competitive carbonic anhydrase inhibitor. Okay, and indications in glaucoma, increased intracranial tension, metabolic alkalosis, mountain sickness, forced alkaline diuresis. Okay, these are the indications of carbonic anhydrase. Where are they contraindicated? All the chronic diseases, remember, they are contraindicated. Chronic kidney disease, chronic obstructive pulmonary disease, and chronic liver disease, CLD, CKD, and COPD, and drug allergy. If there is allergy of a drug, you should never give that drug. Okay. Side effects. What are the side effects? Metabolic acidosis. Why this acidosis is occurring? This particular carbonic anhydrase, it increases HCO3 loss in kidney. So there is acidosis. This is a buffer, right? It is a basic buffer. So if base is going out of the body, it causes acidosis. Next is hyperchloridemia, then is hypokalemia, then is hyponatremia, then is renal stones. Okay, because of combination with calcium. Okay. Examples. What are the examples for these drugs? What are the name of the drugs? Acetazolamide, brinzolamide, dorzolamide. In acetazolamide, it is oral and IV preparation, whereas brinzolamide and dorzolamide, they are topical. They are topical given as eye drops. Okay. Next, coming to sodium glucose transporters inhibitors, where they act again, they act on PCT. What is the mechanism action? What is their action? They act on sodium glucose transporter 2, which is present in kidney. They inhibit that particular transport. Okay. So where are they used? They are used in type 2 diabetes mellitus, congestive heart failure, and microvascular complications, reducing capacity they have. Okay, like CAD, MI, and angina, and diabetic nephropathy. In diabetic nephropathy, the first drug of choice is AC inhibitors, then it is SGLT2 inhibitors. Contraindications, they are not indicated where in impending case of AKI, that is acute kidney injury, you are not going to give it. Then diabetic ketoacidosis, then peripheral vascular disease, these are contraindicated. Next, side effects. What are the side effects? Hypovolemia. Okay, they are going to remove glucose also. With glucose there is always water, so water also will be lost. So hypovolemia, orthostatic hypotension, because of decrease in volume there is hypotension. Because of that hypotension, the patient will repeatedly fall and cause bone fractures. It is most commonly seen with canagliflozin. Okay, canagliflozin has this ability to cause maximum. Next is glycosuria, because there is glucose in the urine and that urinary tract will be having glucose adherent to it, so it will cause increased risk of UTI. Then Fournier's gangrene in case of males and vulvovaginitis in case of females. Okay, what are the drugs under them? Dapagliflozin, empagliflozin, canagliflozin. In this, canagliflozin is not used nowadays because of its side effects like bone fractures. Dapagliflozin and empagliflozin, they are approved for congestive heart failure. Okay. Next, we'll go for mannitol. Mannitol, what is the site of action? PCT and descending loop of Henle. Okay, it acts on both. Okay, what is its action? It has osmotic effect. Okay, it will inhibit water reabsorption and loss of water is promoted. Okay, what are the indications? Again, intracranial tension is increased, acute refractory glaucoma. What is refractory? It doesn't mean even after giving so many drugs like acetazolamide, dorzolamide, brinzolamide, all those topical antibiotics and IV and oral, it's not effective. So at last, mannitol is given for that glaucoma. Then it is cerebral edema, post-dialysis disequilibrium syndrome, impending renal failure. All these we have mannitol. Okay. Contraindication, it is again congestive heart failure with pulmonary edema. Why? Because it brings about the water from the water out again because of osmosis, and it will, what that osmosis will cause, fluid enter into the interstitium of the lung, and that will cause pulmonary edema. Okay, and heart failure also. In combination of these two, you are not going to give mannitol. Acute cerebral hemorrhage. Okay, in case of acute cerebral hemorrhage also, because of osmotic effect, you are not going to give mannitol. In case of CKD, because this mannitol is excreted through kidney, so in case of CKD, you are not going to give mannitol. Okay. What are the side effects? Volume overload leading to congestive heart failure, I told you, because of osmosis. Electrolyte imbalances. What are the electrolyte imbalances? Hypernatremia and hyperkalemia occur. Okay, nausea, vomiting. Okay, they are the GI symptoms. And metabolic acidosis again. Next is loop diuretics. Where are they acting? Ascending loop of Henle, that is thick part. Ascending loop of Henle is two part, right? See here, it is thin part and this is thick part. In thick part, this particular thing is acting. Okay, it is acting. What is its action? Na plus K plus 2Cl symport is inhibited. Okay, it is inhibited. They are high ceiling diuretics because they excrete all ions. Okay, all ions. They don't spare any ions. So there is loss of all ions. Indications is congestive heart failure with pulmonary edema, pedal edema, CKD with periorbital edema, hypertension, hypercalcemia and hyperkalemia. Okay. Where are they contraindicated? They are contraindicated in case of sulfur drug allergies. Okay, known case of sulfur drug allergies. Electrolyte imbalances like hyponatremia and hypokalemia. Okay, they are going to lose all, right? So they are contraindicated. Already there is hyponatremia and hypokalemia. Again, if you give diuretics, loop diuretics, again they lose in the urine. So they cause electrolyte imbalances. Okay, then it is chronic liver disease with diabetic encephalopathy, you are not going to use loop diuretics. Then it is hypotension because of loss of water. Side effects is metabolic alkalosis and metabolic acidosis, paresthesia and weakness and fatigue, ototoxicity and hyper metabolic states like hyperlipidemia, hyperglycemia and hyperuricidemia. These are all the metabolic complications. Okay, these they are metabolic. What are the drugs under them? Furosemide and torsemide. Furosemide is given as for higher diseases. Torsemide for pedal edema, it is preferred. Okay. Next we are going to see thiazides. In thiazides, what are the site of action? What is the site of action? Early DCT. Mechanism of action, there is Na plus Cl minus symport that is inhibited. What are the indications? Hypernatremia. Okay, hypernatremia in case of diabetic insipidus. Okay, there are two types of diabetic insipidus, central and nephrogenic. In case of central it is desmopressin, in case of nephrogenic it is hydrochlorothiazide. Then maintenance treatment of hypertension, hypocalcemia, like an add-on therapy with furosemide for congestive heart failure. Okay. Contraindications same like loop diuretics. What are the contraindications of loop diuretics? I mentioned here. What are the contraindications of loop diuretics? Sulfa drug allergy, electrolyte imbalances, CLD with hepatic encephalopathy and hypotension. Not going to use loop diuretics. Same will be applicable for thiazides also. Same is applicable for thiazides also. But what are the side effects? Again same loop diuretics, but exception is all ions are not lost here. No loss of calcium. Okay, no loss of calcium. So calcium is retained. Okay, but there is a maximum risk of hyponatremia. Okay, repeated hyponatremia is a feature of thiazide treatment. Okay, hyperlipidemia. Okay, but this particular metabolic side effect, it is less in case of thiazide. Like that's why they are in trend now. Like chlorothalidone or indapamide, these are the present drugs because of less side effects like hyperlipidemia. Okay, the examples of drugs under them is hydrochlorothiazide, chlorthalidone and indapamide and metazolone. What is metazolone? Again it is a thiazide which is preferred in case of less GFR, decreased GFR. You are going to see, you are going to use metazolone. The next is K plus pairing. What is a K plus pairing? What is the site of action? Late DCT and cortical. I told you they act together. The mechanism of action is two types, ENaC channel inhibitor and aldosterone receptor antagonist inhibitor or inhibiting of RAS system. For here, what are the drugs? I am saying it now itself. It is amiloride. Here it is ARA, that is and aldosterone receptor antagonist, spironolactone, eplerenone and finerenone. Indications. What are the indications? Resistant hypertension, congestive heart failure. Why? To prevent cardiac remodeling. Repeated hypertension can lead to changes in the heart anatomically and physiologically. That particular thing is called as cardiac remodeling. There are so many drugs. In that, potassium sparing diuretics are also one, like beta blockers are also used to prevent cardiac remodeling. The next is primary hyperaldosteronism, that is Conn syndrome. Ascites, nephrotic syndrome, anasarca, wherever there is fluid, especially in case of hepatic failure, ascites occurs. There it is most commonly used. Okay. Hypokalemia, hirsutism, all these can be caused. Why? Because it is sparing potassium, so it can be used as an advantage in case of hypokalemia. Contraindications. CKD should not be given with ACE inhibitors of ARB because these also cause hyperkalemia, and if you give again potassium sparing, the hyperkalemia will be more. Arrhythmias also, because hyperkalemia will precipitate arrhythmias. What are the side effects? Hyperkalemia, I told you it is sparing potassium, so it is causing hyperkalemia. Metabolic acidosis. Why? Because K plus is an positive ion, so it is causing, it will exchange with hydrogen and it causes metabolic acidosis. Then sexual dysfunction in case of early treatment and gynecomastia in case of chronic treatment. Okay. The last part is antidiuretics. Now we have done with diuretics. Next we will move it to antidiuretics. In that there are two subunits, that is ADH analogs and ADH antagonists. First we will deal with ADH analogs. What is their site of action? Medullary collecting duct. What is their mechanism of action? V1 receptor agonist and V2 receptor agonist. V1 receptor it is terlipressin, V2 receptor it is desmopressin. Terlipressin is used in case of acute bleeding in case of esophageal varices, whereas desmopressin it is used in case of central diabetic insipidus. I told you in case of central diabetic insipidus it is desmopressin, whereas in case of nephrogenic it is hydrochlorothiazide. Okay, it is a thiazide diuretic. What are the indications here for this particular ADH analogs? Induction of labor along with oxytocin, acute bleeding, the disease of visual varices, central diabetes insipidus, nocturnal diuresis or bedwetting in case of newborns, renal concentration testing, it is a test, okay, there it is used, and hemophilia and von Willebrand's disease. These particular analogs, they release the factors for hemophilia like factor 8 and von Willebrand's factor, so it is used in case of these diseases. Contraindications: ischemic heart disease, hypertension, chronic nephritis, primary polydipsia, which is a psychogenic one, okay. Secondary polydipsia is different, okay. Here it is primary, some psychogenic cause is there, some psychiatric cause. What are the side effects? Nasal decongestion. Why? Because this particular terlipressin, desmopressin, they can be given nasally through nasal spray. Epistaxis, abdominal pain, hyponatremia, all these are caused. What are the examples or drugs under them? Desmopressin, lipressin and terlipressin, okay. These are the drugs. ADH antagonists. What are the ADH antagonists here? What is the site of action? Medullary collecting duct. What is the mechanism of action? V2 receptor inhibitors, okay. V2 receptor inhibitors is called as vaptans. So what are the indications? Hyponatremia, due to congestive heart failure, cirrhosis of liver, and SIADH. What is SIADH? Syndrome of inappropriate ADH secretion, okay. What are the contraindications? Should not be given with the drugs using the same CYP3A4 isoenzyme, okay. If there is a drug using this particular isoenzyme is not present to metabolize this particular drugs that are vaptans, so this particular vaptans are not metabolized and they don't bring up any action in the body. So hypovolemia and hyponatremia, okay. If there is a hypovolemia and hyponatremia together, then you should not use it. Then it is side effect. What are the side effects? Thirst and dry mouth. What are the examples of drugs? I told all vaptans come under ADH antagonists, okay. Tolvaptan, mozavaptan and conivaptan are the drugs. These two are specific for V2 receptors, whereas conivaptan, it acts on V1A also and V2 also, okay. Thank you. Please like, share and subscribe if you like it.